and we are very pleased to have Dr. Collichio with us here today. Immune checkpoint-related adverse effects. Dr. Collichio, hello and welcome.
Hi, everybody. Thank you for tuning in.
So glad to have you here today. Let's see, we know that you're an MD at the Lineberger Comprehensive Cancer Center and Professor of Medicine at UNC Chapel Hill's Division of Hematology and Oncology. You've had several leadership positions in education in the United States, including a term at the American Society of Clinical Oncology, that's ASCO, on their Education Council, a representative for the Association of Subspecialty Professors and of the Alliance of Academic Medicine, and chair of ASCO Oncology Training Program Committee. Academic mission to advance training of physicians in the United States, particularly oncology trainees. And you've been on, your clinical research mission is with melanoma. All right. What's one thing we should know about you, Dr. Collichio, that wasn't on your professional bio there?
I've been making art out of candy wrappers.
Wow.
Take a picture one day, Tim, and show you.
I would love to see that.
I have a hobby.
That's really interesting. I had no idea. All right. So I mentioned poll everywhere. We try to make this first question kind of a softball. So immunotherapy is a type of cancer treatment that can help your immune system fight cancer. And if you believe that's true, you can go ahead and put A, false, B. And while you're looking at that, I'm going to read the disclaimer. This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Francis Collichio, MD, has no financial relationships with commercial interests as defined by the ACCME. And so here's that poll everywhere poll. And immunotherapy is a type of cancer treatment that helps your immune system fight cancer. We're running 96 or 97% on the affirmative, on the true. Dr. Collichio, how are they doing?
Great.
Good.
That's the right answer.
All right, good. Well, there'll be more. These are all anonymous, so we hope you'll take the time to respond to all of these poll questions. And without further ado, immune checkpoint-related adverse effects with Dr. Fran Collichio. I'll turn it over to you.
Yeah, and so since we're in different places, Tim is going to advance the slides as we go along. Tim, you can go ahead to the next slide. So the outline for today is to review the mechanism of the checkpoint inhibitors, and then to go over the immune-related adverse events in three different ways: the events we think about, the events that are common but we don't think about them, rare events, and then a new term called delayed immune-related events, or DIAR. And if there's some time at the end, maybe we can talk a little bit about how to integrate this work with the COVID pandemic. Next slide. So the mechanism, next slide. So I always teach my patients to think about systemic therapy in terms of 5 buckets of treatments. Chemotherapy is the traditional old way of thinking. A lot of patients still think that they're going to get chemotherapy. In fact, sometimes the treatment is billed as a chemotherapy and they get confused. Then there's hormone therapies, which are commonly used in breast cancer and prostate cancer. Target therapy are the therapies that we use when we identify a gene within the cancer for which there's a medicine that can attack it. Biologics are therapies that don't necessarily work with your own immune systems, but they're biologically produced. And the last bucket, the green one, is what we're focusing on in the next hour, and that's the immune therapies that are using the checkpoint. Next slide, please. So really, I think it's fine to call this a revolution, and the revolution in cancer came when the checkpoint in the immune system was discovered. I think it turned out around 2016. So a lot of this is right here with us right now. It was really a lot of fun in my career to see this all come about. Next slide. So this is a really important cartoon. Spend a lot of time learning and maybe drawing on your own so that you understand it. And maybe later on you can also go to the internet and see how this works with viruses. But basically you've got a antigen, which is that red diamond in the picture. That could be a cancer or that could be a virus. And it's serving as a flag to that purple cell, which is the dendritic cell. And then they line up with the T cell, and there are three signals, signal 1, signal 2, and signal 3, which is represented by the red word called cytokines. When everything lines up, the immune system is on, and the immune system is attacking the cancer. Tim, can you click? But if we're constantly attacking the cancer, then what happens is we would always be inflamed all the time. And so biologically speaking, there is this checkpoint that has developed which turns off the process, and I show it here as a CTLA4 checkpoint. So now this is in the off mode. Tim, please click. And then that red thing that is represented as a Y is an antibody. And the one that we use most of the time in the United States is ipilimumab. So this is an inhibitor to the checkpoint, so it's an off to the off. And when this happens, the immune system comes back on. And this is happening away from the cancer, so in the lymph nodes or the spleen or other parts of the body. Next slide. The other checkpoint is happening at the cancer and as well as other parts of the body. And here in the cartoon, I represent the T cell as the blue cell and the tumor cell as a off yellow-green cell. And they are together working initially until the PD-L1 and the PD-1 turn it off. So this is already off. Tim, please click. And so we have other antibodies, which are the anti-PD-1s and the anti-PD-L1s that turn the off and keep the immune system on. So keep those 2 points in mind as we go forward in this presentation. Next slide. So why can't we use the immune system to fight all cancers? And spend a lot of time maybe after the talk looking at this. This is a really great slide. And you can think of it in 4 parts. Click, please. So the first part is to think about the systemic immunity. How strong is someone's immune system? When you think about it, young people have very strong immune systems. And so they may have a better immune system to get rid of their cancer than an older person. Click, please. Click again. I'm trying to get you guys over to the tumor genome, epigenome. That is, some cancers are really easy to see by the immune system. And the cancer that is most easy to see is melanoma. It has a lot of signals that tell the body that it's foreign. And that's why we were able to use treatments to kill it. Click, please. And then there's the tumor microenvironment. Where's the cancer hanging out? What's going on there? Does it have a rich blood supply so that treatments can get to it, or is it blocked off by scar tissue? So cancer like pancreatic cancer is quite blocked off by scar tissue and it's harder to treat. Click, please. And then there's the internal environment, that's your gut. And you need actually to have a healthy gut to make this work. We've learned that there are bacteria that live in our gut that make the treatment work better. And one more click. And then I added this circle. Click, please. There should be 2 people in the center. There they are. And what this is to show us that there are also the system around you, the loved ones that help you, getting to the doctor, all of that that needs to work well in order for the therapy to work. Next slide. So when we think about those initial cartoons of the white blood cells getting together and how this system is turned on, now you should appreciate that when you do this treatment, you can generate white blood cells anywhere in the body. So the side effects that we're going to talk about can be anywhere in the body. We used to just think a few parts, but it gets growing and growing every time we think about it. So next slide. So these are the events that we think about, and I think these are the events that we think about when we've been using these medications. Some of the cancers are just getting on board to using the checkpoint medications, and so you may not think about them as much. So I'm just going to characterize the next part of the lecture like that. Next slide, please. And we're going to do it by case, so that when you go back through this, you'll have cases that you can look at, and you'll have clues in terms of what body part we're talking about, because there are differences here and there on how to handle these things. Okay, so we have a 65-year-old gentleman who's on pembrolizumab, and he comes to clinic for his second cycle of treatment. He's been feeling well. He has a mild macular rash here and there on his medial forearm. It's not pruritic. An example is shown in the photograph. So look at the photograph. You can see in the upper arm there are these little pink blotchy areas. His labs are normal. Can treatment be given today? Now, a lot of you may already know the answer, but if you don't, that's my job, is to explain to you how you come up with it. So next slide. What you need, the key concept number one, is you need a consistent tool to grade the side effects that your patients are having. And so you could get this by putting a PDF on your computer, or you can Google it, or you could get an app, but it's called the Common Terminology Criteria for Adverse Events, or the CTAE. And we're up to version 5. And in this, you can have a side effect that's grade 1, 2, 3, 4, or 5. Next slide, please. So if we take that document and we were to control find rash, we would come up with this page on skin and subcutaneous tissue disorders. And looking down towards the bottom, our patient has a macular papular rash. And I show it in the red bar what kind of rash he has. Next slide. The next tool that you need is to have guidelines, and these guidelines are the National Comprehensive Cancer Network guidelines, and they have all of this spelled out there in the management of immunotherapy-related toxicities. So look it over to make sure you know where to find it on your computers. Next slide. And here's our patient. He has macules and papules covering less than 10% of his body, with or without symptoms. He's grade 1 with his rash. Next slide. And click, please. So we know that for grade 1 toxicities, you can continue the immune therapy. So our patient can get his pembrolizumab treatment that day. And this slide is the general guidelines for all of these. If your patient has a grade 1, you can continue. If your patient has a grade 2, you will often delay, but depending on the clinical situation, I've seen some physicians and some patients choose to take treatment with grade 2s. Grade 3 and 4, you definitely do not want to treat the patient that day. You definitely want to pay close attention to what they're saying to you. And usually you initiate glucocorticoids. The doses can be quite high. And we'll go through some of that in the next examples. Next slide. Okay. So now we're on a next case, okay? This is a 28-year-old man on ipilimumab. And ipilimumab is the CTLA-4 inhibitor. He's also taking nivolumab, and he comes every 3 weeks for his metastatic melanoma to the lung. When he presented to the clinic before the start of his second cycle, he said he had 3 loose stools per day for the last 2 days. He had no associated abdominal pain, blood in the stool, or fever. On exam, he appeared well and vital signs were normal. Can you give him treatment today? Well, this is a real-life case that I saw many, many years ago, and we were developing all the criteria then, so I was nervous. And next slide. I rated all this as diarrhea. That's what I was looking at. I still saw that it was low grade, but I was still nervous. Next slide. Next. So I admitted him to the hospital. The patient was admitted to the hospital overnight. I gave him fluids. He did well. He only had 1 loose bowel movement in the hospital, so he got discharged. But 2 days later, when he came for his scheduled post-hospital follow-up, he said he had 7 watery bowel movements in the last 24 hours. And on the ride in, he felt feverish, he had chills. There's his temp, 101.5, he's tachy. He's flushed, his abdominal exam has some tenderness, no rebound. His white blood cell is high, hemoglobin is okay, platelets are okay. He's got a left shift with an absolute neutrophil count of 10. His ALC is low, which we commonly see on immuno-oncology. The lactate level is normal, and the CMP is normal. Okay, so as a provider, we're seeing this guy, he's sick, he's on Ipi/Nivo, he now has grade 3 diarrhea. Lots of things are going through our head. Next slide. So we have a diagnostic plan, and this is what the patient should have done diagnostically when they are seen with grade 3 diarrhea from one of these drugs. Stool culture should be obtained. A C. diff test should be done. The stool calprotectin, which is usually used for Crohn's disease, should be ordered. A CAT scan can be considered. A CAT scan can be very helpful because these patients can have perforations, and so this can show up as gas on the CT scan, as well as you can see the thickening of the bowel wall, which can be helpful to diagnose colitis. Colonoscopy is the gold standard. The QuantiFERON Gold hepatitis serology are important, and why? Because we may need to reverse the side effects, so we need to know if the patients have ever had TB or hepatitis B or C. And by pan-endocrine labs, I mean thyroid, cortisol levels, etc. We're going to go through that. And that's because if you get an immune-related adverse event as serious as colitis, diarrhea, then other things can go wrong too. Next slide, please. The patients are admitted to the hospital with grade 3 diarrhea. We usually make them NPO at the beginning. Advanced diet slowly clears, etc. They're treated with high-dose steroids. If the patients don't quickly improve in 48 to 72 hours, they are given reversal medications. We could talk about that term, infliximab or vedolizumab, as quickly as you can. Next slide. This is what the colonoscopy looks like for patients who have immune-related diarrhea. The slide on the far left, you can see the endoscopic appearance, and there are little specks of red in the bowel wall, which correspond to the inflammation. And on the biopsy, we are seeing what are called crypts, which are those air pockets within the mucosa. And this can be confused with C. diff. So it's important to keep that in mind, that this will look just like C. diff. Next slide. Here is how you manage diarrhea/colitis, because it can be difficult to know if the patients are having diarrhea and colitis or colitis. Grade 1 is mild. They can be treated with bland diet. Some people use loperamide, plus or minus diphenoxylate and atropine. You can delay the ipilimumab. For grade 2, I like to do colonoscopies for grade 2 because there's where I may be not as sure what the diagnosis is. They also get steroids. You can hold the immunotherapy. If the patients don't get better, you continue treatment as per grade 3. And grade 3 is the case that we just went through, plus the high-dose steroids. You stop immunotherapy, you stop ipilimumab. That's a permanent stop. The other medications you might consider re-challenging when the patient gets better. And as I said, if the patient doesn't get better in 48 to 72 hours, you consider infliximab. Now, when you go to your NCCN guidelines, you see that the steroid use for these patients is very long. For grade 3 toxicity, it generally takes about 2 months to get the patients off steroids. I start high. I give the 2 milligram per kilogram dose the first few days, and then I drop down to get the taper over the next 6 to 8 weeks. And the patients need to be monitored in the clinic frequently. Next slide. So steroids need to work quickly. That's your key concept 3. If the symptoms don't improve in a few days, consider further immunosuppression. Next slide. Okay. This is another one that we think about. A patient with who's 48. She has COPD. She has metastatic adenocarcinoma of the lung, and she's admitted with pneumonia. That's the diagnosis that she carries when she's sent up from the emergency department. Her cancer was diagnosed 6 months ago, and she was treated with monthly nivolumab. 3 months into the treatment, her scan showed stable disease. But on presentation this time, she's got an O2 stat of 85%. Her blood pressure is okay at 135 over 80. Her temperature is low grade. Fever at 99. The CAT scan is shown. I think you all can appreciate that the CT scan is showing consolidation, some air bronchograms. I can tell you because I've seen this lady's other CAT scans and I could not find the cancer within here. So I think most of it is this acute process. Next slide. So what does this patient have? Does she have pneumonitis, an atypical pneumonia, lymphangitic spread of her cancer, or adult respiratory distress syndrome? So right, yeah, so this is a lecture on immune-related adverse events, so we're all going to pick pneumonitis, and that is the correct answer. You have to treat her as if she has pneumonitis. Now she may have atypical pneumonia as well, and she may have ARDS as well, so it's not a really great question. I wouldn't throw it out of a board exam, but I think the point's well taken is err on the side of the inflammation first. Next slide. So all these things are running through your heads as you're working this patient up. You got the chest x-ray, you got the CT scan, you're seeing the radiographic findings. You can consider a bronchoscopy, and we did a lot of these years ago, but now I think we understand what we're dealing with more, so we don't order as many bronchs. If you do bronchoscopy, the typical lavage will have a lot of T cells and CD8 positive T cells, which are the cells that we saw at the very beginning of this talk that we have stimulated. Pulmonary function tests can be helpful. They can show a diffusion problem, and blood gas may be predictive how well the patient will do. You have to treat these patients with IV steroids, just like we did with the colitis case. The patient's very sick. Albuterol nebulizers, oxygen, and most of the time we'll give prophylactic antibiotics, antifungals to patients who are on high-dose steroids. Just like the colitis case, you add mycophenolate or infliximab if the patient doesn't do well. And I've recently saw some case reports where they treated patients with IVIG. Next slide. Pneumonitis occurs rarely in melanoma patients, about 1% to 2%, but it's much more common in lung cancer, and I think it'll probably be even more common as we recognize it more and more. It's a little bit late onset, 9 to 19 weeks after starting a PD-1 inhibitor. The symptoms are the dry, unproductive cough, dyspnea, cyanosis, fatigue, and then the differential diagnosis we just discussed. You have to recognize this because if you don't and you gave the patient treatment, you could get chronic, irreversible lung disease. Next slide. Okay, now we're on our next case. We have a 65-year-old who is on ipilimumab and nivolumab for metastatic melanoma to the liver. He has had 2 treatments when he presents for an unscheduled visit with right upper quadrant abdominal pain and bloating. No fever, no diarrhea, but his stools have become lighter in color. The CBC shows a mildly elevated white blood cell count. Otherwise, it's normal. The transaminases are very high, ASTs 340, ALTs 410, alphas 810. Bilirubin is normal, protein is 6.2, albumin is 3.8. So when you guys are looking at this slide, the CAT scan that you see on the top is the patient's initial CT scan showing the metastasis in his liver. And the CAT scan below that is the CAT scan the patient came in when he saw me with these blood tests in his clinical presentation. So, tough case. what's going on in your mind about differential diagnosis of these spots? Next slide. Does this patient have progression in his cancer? Does he have immune-related liver toxicity? Or does he have underlying hepatitis B that's gotten reactivated? Or does he have progression of his disease and immune-related liver toxicity?
All right, let's take maybe 5 more seconds. Thanks so much for all of the responses.
Yeah. So guys, everybody is right. Sorry, I'm a nice teacher. I'll get the pass. This case actually was biopsied. He did have immune-related liver toxicity and CD8 positive T cells in his liver, and he had over time progression in his cancer. Liver tumors did grow. Tough case because with ipilimumab you can get pseudoprogression, so we didn't know at the time. Next slide. So hepatitis occurs from these medications. It occurs 30% of the time when you combine ipilimumab with anti-PD-1 and 10% with PD-1 inhibitors alone. It occurs 8 to 12 weeks after starting the single agents. Sooner if you put them together. There can be a waxing and waning picture of hepatitis induced by anti-CTLA-4 antibodies. The symptoms and signs are usually based on elevated liver function tests. Patients have bloating, dyspepsia, jaundice, nausea. And the biopsy shows the CD8 positive T cells. Next slide. Tim, can you advance? Okay, so you treat these guys with high-dose steroids, followed by oral taper. And here's a pearl. Infliximab, because of its potential for hepatotoxicity, should not be used in this setting. If patients don't rapidly improve from steroids, give them mycophenolate. Next slide. Okay, we're on the next case. Is everybody doing okay so far? Okay. So we got a 52-year-old with advanced kidney cancer, and he's on ipilimumab and nivolumab. And he has neck pain and headache 2 weeks after his first cycle. He states it's harder to drive because his peripheral vision is off. Prior to starting the treatment, he had a normal MRI of the brain. On exam, he's hypertensive. Otherwise, vitals are okay. His labs are shown. White count's a little bit high. Sodium is 129, potassium is 5.2. The creatinine is okay, liver function is okay. All right, so what's going through everybody's head about why he's having headache? Next slide. Go ahead, click your buttons if you can. Does this patient need, do you need to order a cortisol level, an ACTH, thyroid function test, an MRI of the brain, pituitary image, or all of the above? Everybody's already answered. The answer is all of the above. What diagnosis are we thinking about? So next slide. This is hypophysitis. So this is another diagnosis that we think about a lot for when these people are on these medications, and we do not want to miss this diagnosis. What happens is that the patients who are receiving ipilimumab can have a direct binding of this drug to their pituitary cells, and this can cause the pituitary gland to get inflamed and shut off. And so with the inflammation, the patients get headache, fatigue, muscle weakness, and they describe the peripheral vision being off. And they can present with low sodium, high potassium. When you check their blood, the hormones that are made by the pituitary gland are not there. So you have a low ACTH, a low TSH. The classic thing I'll see is the low cortisol level and low ACTH. Remember to have your patients, if you're kind of on the fence and you don't know if they're having this, you remember to have them come in the morning to get their blood work. The cortisol level has to be measured before 10 a.m. And this can be one of the permanent sequelae of these treatments with secondary hypothyroid recovery has also been reported. Next slide. Okay, this is our next case. This is a 54-year-old man also on ipi/nivo for metastatic melanoma to the brain. He presents for his third cycle. He's been feeling shaky lately, shaky. Blood pressure is 134/74, his heart rate is high. Temperature is 37.1, his exam is normal. But you know, I always see patients with high heart rate. It's just normal. CBC and CMP are normal. So I think, okay, he's 54. I'm trying to really help this man with ipi/nivo for metastatic melanoma. I'm going to send him to the infusion to get started, get the IV going. But then 60 minutes later, here's his labs. Click, Tim. TSH is very low, 0.15. Free T4, 4.65. What is his diagnosis?
And again, it's great.
Yeah, so this guy has hyperthyroidism. Next slide. And so here are the endocrinopathies you'll see with these drugs. Hypophysitis typically occurs with the CTLA-4 antibodies, as we said, because the ipilimumab has to bind to the pituitary gland. Hypothyroidism is one of the more common things we see in clinic, and it's not as dramatic as hyperthyroidism. The hyperthyroidism, as in this case, you'll see the high T4 and the patients will be shaky. A type 1 diabetes can be caused by these drugs. And the PD-L1 has a slightly lower risk. Next slide. So for your diagnosis of thyroid conditions, hypothyroidism, patients will have a high TSH and a low free T4. There can be many patients out there with a high TSH and a normal free T4. I usually don't treat these patients unless they're having a lot of symptoms of hypothyroidism. For hyperthyroidism, you have the low TSH, high free T4, high free T3. And same thing, you could have a low TSH and a normal free T4 in a subclinical case. For Graves' disease, which is very rare, you would get anti-thyroid peroxidase and antibodies, anti-thyroglobulin antibodies. I type in TPO and TPI, and that's how I get these blood tests ordered. Since most of the patients don't have Graves' disease, I don't order it anymore. Usually this is a direct binding to the thyroid gland, and it causes the thyroid hormone to pour out. And so for the next month, the patients are hyperthyroid. Then they burn out their gland and they become hypothyroid. If the patient is symptomatic from their hyperthyroid, you should treat them with a low-dose beta blocker. Next slide. So here we got it, hypothyroid watch, hyperthyroid. The corticosteroids could be given in severe cases, beta blockers for the tremor, and an endocrine consult. Next slide. Okay. So those are the events I think we think about all the time since using these drugs commonly since 16. But now we're going to go through some that are common and we forget to think about them. Next slide. So here's a 54-year-old with lung cancer metastatic to the liver on nivolumab. She comes from her third cycle. She's doing well, but she's complaining of pain in her left side of her mouth. On exam, her oral mucosa is pink and dry. There are no abnormal lesions. She has no swollen glands. There is fullness over her left parotid gland. So you're developing your differential diagnosis. Next slide. And here's your choices. The patient could have mucositis, thrush, a metastasis to the parotid gland, or Sicca syndrome. I'll give you just 15 seconds. And the answer is Sicca syndrome. Choice D. Yeah, thanks. Now you can all click D. Next slide, Tim, and I'll tell you guys why. Okay, so remember, for mucositis, which we've been seeing for my entire career, from chemotherapy, the patient should have red, denuded mucosa. So that's why this is not mucositis. For thrush, there should be some white spots in the patient's mouth, and that patient does not have it. It would be unlikely if the patient had metastasis in the parotid gland. So this is Sicca syndrome. This is a very dry mouth, and it's a kind of part of the Sjogren syndrome. The truth is that if you get these antibodies, which you see mid-slide down, the ANA and SSA and SSB, I'm going to tell you guys it's highly unlikely that those would be positive. Just like so many immune-related adverse events that are out there, when we screen for the antibodies that we've known for years and years, they are not there. So this is probably a different means by which this has happened, but the patients still feel just as bad. So if you start asking your patients, I bet you they're going to tell you they have dry mouth. And the easiest way to treat this is with one of the moisturizers that are on the market, Biotene, is really helpful. In severe cases, you can order an oral corticosteroid rinse. Next slide. Okay. Another side effect that happens all the time, and we forget to think about it, but it really affects quality of life, and it can affect quality of life long after these treatments are done, is in your typical adult patient who has osteoarthritis. These people can have worsening of their known joint pain. Or the young patient who has an old injury, maybe an ACL injury from skiing or something like that. The patients will come to you and they'll say, gosh, my joints hurt more than they used to. You can treat them with NSAIDs. We send a lot of patients down the road to orthopedics for steroid injections. That should not affect the outcome of the cancer care you're trying to give the patient. Next slide, please. The other thing is neurotoxicity. So patients will have neuropathy all the time, and neuropathy in very bizarre places. We've seen people lose their taste, their smell, getting pains down their legs. So any kind of neuropathy that you're used to seeing from chemotherapy can happen, and then on top of that, bizarre neuropathy. So here's a biopsy showing you the sural nerve, and the yellow arrow is pointing to, guess what, white blood cells, which are CD8 positive T cells. And then the teased fiber shows you all those black spots where there are white blood cells accumulated on the nerves. Next slide. I didn't tell you how to treat neurotoxicity. We usually treat it with gabapentin or duloxetine. So rare events that you need to think about are coming up next. Here's the next one. Nephritis. So inflammation of the kidney does not happen very often. It's probably happening more than we know, but it's still not that common. Very, very difficult to diagnose. The better way to diagnose this is to do urine analysis. Why? Because I'm looking for, guess what, white blood cells. If the UA does not have white blood cells, it's highly unlikely to be nephritis. Guidelines are driven by the creatinine. If I'm worried that my patient might be having nephritis, I will hold therapy, talk to my nephrology colleagues. The gold standard, unfortunately, is a kidney biopsy, which is very, very difficult. Next slide. Okay, don't forget these that I'm coming up with next. Don't forget these rare but serious side effects. So if you're out there thinking about doing adjuvant therapy for patients, people that might already be cured of their cancer, it's very important to remember to tell them about these rare side effects. Next slide, please. So here's the first one. It's rare, but it happened. An 81-year-old gentleman with chemistry professor was admitted after being treated with ipi-nivo for kidney cancer. He had to go right to the ICU because of chest pain, and he was diagnosed with myocarditis. After stabilizing his heart, he was transferred to the floor. and his nurse called the resident physician because the patient was having abnormal breathing. She observed that he was using his abdominal muscles to breathe, and he could barely speak. He said he couldn't swallow his breakfast. So hopefully you're generating a differential diagnosis. Click, please. He goes back to the intensive care unit, click. And he's diagnosed with serum-negative myasthenia gravis, click. He's treated with 1,000 milligrams of methylprednisolone per day, tapered to 80 milligrams, click. Pyridostigmine, click. Plasmapheresis. So this is one of the dramatic cases. Area was protected, and unfortunately this patient passed away. Obviously he wasn't being treated for adjuvant disease, but caution out there. Next slide. So key concept 5 is that when you combine the CTLA-4 and the PD-1 inhibitors, you get more toxicity than when you use either alone. Anti-CTLA-4 by itself is 34%. High-grade toxicities from the anti-PD-1s, anti-PD-L1s are 14%. When you combine ipi-nivo with the standard doses used for melanoma, it's 55%. Next slide. And what you're going to be seeing more and more are these unusual combinations where we look at other agonists and antagonists and come up with more and more antibodies to treat. In addition, chemotherapy with immuno-oncology, radiation therapy, target therapy, and VEGF are all being used, VEGF inhibitors are all being used in the clinic. Next slide. So I can't give a talk without describing oncolytic viral therapy. Many of you out there might be sending your patients to me to receive a treatment, and during our pandemic, I think it's also helpful to see a little bit of information about viruses. Next slide. So this is a treatment that is FDA approved. We call it TVAC. It's also called telemagene voraplasmid. Click, please. So what is happening is that TVAC is delivered into the cancer, click, and what happens is that the cancer starts to break apart, and the proteins that are in the cancer are released, and the GM-CSF, which has been attached to this virus, starts to have white blood cells enter the area, which are shown in the light blue, click. And then we then create the dendritic cell activation and an immune reaction, click, and then the cancer dies. Next slide. And so TVAC is given in our clinic at UNC, so most places send their folks to us. Whenever there's tumor above the skin, I will inject it. If there is tumor below the skin, Dr. Lauren Burke and her colleagues in ultrasound will inject it. Next slide, please. And that is a case, a gentleman who was treated many years ago, and those mounds of tumor went away with therapy. Next, click. And this gentleman is doing very well. He had tumor injected near his neck and distant sites near his adrenal gland, and in his abdominal cavity went away too. Next slide, please. Next. And this is what TVAC looks like. It's got a reminder of what a virus is. And so the genetic material is the blue Collichio in the middle, and then the protein covering is on the outside of this virus. What's really important about this virus is that it's very fragile. So if I accidentally get it on the surface of the area where I'm treating the patient, it only lives for 20 minutes. And we have an anecdote, Beltrax and acyclovir, that we can use to treat the patients if they get dissemination. So far, there's been no person-to-person transmission of this, and it shouldn't happen because of the genes that they deleted. And this virus has been in use for over 10 years now. Next slide, please. When you see it used with the checkpoint inhibitors, there are no added side effects. TVAC causes flu-like symptoms. So when I see patients with in-transit disease, this is first-line therapy, and you can avoid all of the immune-related side effects that you get from checkpoint inhibitors. Next slide, please. But do be cautious because there can be complex patients. Next slide. And here's a case where the patient just finished chemotherapy for a lymphoma, received TVAC. His immune system was poor, and he developed dissemination of the TVAC in his skin that needed to be treated with acyclovir. Next slide, please. Key concept 7 is that sequencing may change your toxicity. Click, please. And these are 3 patients that we had at UNC who all were treated with the target therapy and then went on to receive immunotherapy, and they all developed a red hot rash with hypotension. It looked a lot like Steven Johnson syndrome, but there was no lesions in their mouth. And this is DRESS syndrome, and it can be treated with corticosteroids. So do be careful when you sequence target therapy and immune therapy. Next slide, please. These patients were managed by a derm consult. We kept them in the ICU. They got steroids, and we considered mycophenolate for a couple of them. Next slide. Key concept 8 is what's happening, what's the difference between chemotherapy and immunotherapy? Chemotherapy side effects can be severe, but they are more predictable. Immunotherapy side effects are unpredictable, persistent, and recurrent. Next slide. So study this one after the lecture, please. Take a look at the red curve. That's your chemo. You give the patient the chemo, the patient gets pretty sick, nausea, vomiting, blood counts, etc., but then it gets better. Whereas with immunotherapy, you can have a solid blue line where the side effects build with time, and for some patients, they continue, and weird things can cause the immune therapies to reactivate the side effects. Hopefully, you get the dashed blue line where the side effects stop. Next slide. And so this brings us to another discussion, which is the delayed immune-related adverse events, or DIAR. Click, please. Next slide. So the best slide that we found on this was a literature search, 367 case reports, 194 immuno-oncology clinical trials to collate data where they defined DIAR as immune-related consequence greater than 90 days after stopping the treatment. And you can see this could be thyroid, pericarditis, you name it, a whole bunch of different organ systems have been documenting occurring after the treatment is done. Next slide. And I did not find any good literature to show you about something that I've observed all the time when I go on inpatient wards, and that is when patients have an underlying medical condition, say COPD, say a recent pneumonia, whatever, and then they're treated with these immune therapy drugs. Be careful. Their presentation of their underlying disease could be worse. Next slide, please. So key concept 9 is that this requires a team approach. Our group is led by Dr. Ishsawar Rumi, we all call her, and she has identified physicians across the UNC network that have expertise in this, such as from nephrology, pulmonary, GI, etc. Next slide. All in one stroke, please use the common toxicity criteria to grade your toxicities. Management is based on grade. Patients need to respond to steroids quickly. The good performance status patients who are treated with PD-1 inhibitors have a low risk for grade 3. Toxicity risk depends on sequence, combination, and new agents. Don't forget the rare but important risks to the heart and the brain and other central nervous system. IRAEs can be permanent and recurrent, so be careful when you're doing informed consent. Don't leave this lecture thinking that it's always permanent and recurrent. They just can be. Next slide. These are the references you can read. Next slide. And that's me wearing a biohazard gown. I use a face shield to deliver TVAC because it can splash into the eye. And I think we have time for a couple questions. We're not going to go on to those slides, Tim.
All right, so we are now at the question phase, and we do already have one question that's coming in. Thank you. As a student of radiation therapy, I found this very educational, interesting fact. I gave a small presentation on immunotherapy to my RTT 120 class. And thank you for that comment. We do have this open to additional questions, so we'll take just a couple of minutes here and allow you time to go ahead and submit your questions via poll everywhere. Again, even if you didn't participate in the polls earlier but want to ask a question to Dr. Collichio now, you can just go to pollev.com/UNCCN and submit that question, and I'll keep looking here to see if any questions come in. While we're waiting for those, Dr. Collichio, any thoughts on what special considerations oncologists are given considering the current pandemic?
Yeah, Tim. So I did search PubMed last week to see if there was anything popping up yet. Nothing yet. I reached out to Rumi and I told her I would keep my eye out for cases of patients who have COVID who are on these drugs at the same time. I think we're going to need to figure out how they do. Our organization, Melanoma, received update from the National Comprehensive Cancer Network on considerations, considering do we really give ipi-nivo for patients all the time, or do we think about it a little bit more carefully because they may have decreased access to care? So that's something to be thinking about, is the toxicity of the treatments. Now this week I did treat a patient with ipi-nivo because we're going for an excellent cancer outcome. So I think we still have to keep it in mind. What is our goal and how do we proceed? I spoke with an expert in infectious diseases, and he thinks that the major problem with the COVID virus is the viral load. And if that's true, then we won't have as much inflammation problem. But I think it may be, we have to wait and see what happens as more and more patients get both of these.
Great, thank you. And we do have a comment, great presentation, completely agree with that. And then you briefly mentioned pseudoprogression with CTLA-4I. Does this phenomenon apply to PD-1I and PD-L1I?
Unfortunately, not often. When we first started using PD-1 inhibitors and PD-L1 inhibitors, we thought we'd see it more often, but most of the time, no. So be careful. If they have tumor growth, it's probably true tumor growth. The only differences I'm aware of in the PD-1 and the PD-L1 is there seems to be less endocrinopathies with the PD-L1 inhibitors. And my sense is that PD-L1 inhibitors may be slightly easier, but I don't have any data to support all that.
All right. I want to thank our audience for all of the questions, for all of the participation, and just for being here today in this difficult time. We also want to thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank Mary King, Veneranda Obure, and John Powell for all the work that they've done to make this lecture possible. Of course, we want to thank you, Dr. Collichio, for making time in your busy schedule to be here today.
Of course, you guys take care out there. Bye-bye.
All right. I think you know how you can find us on the web, UNC.